Welcome back to the deep dive. Today we're tackling a subject that frankly feels like a massive biological paradox.
It really is.
Because we are looking at some of the smallest, simplest viruses in existence. I mean, we're talking about tiny genomes, barely enough genetic code to write a grocery list.
Yeah, it's a very small grocery list, like a handful of items tops.
Exactly. Yet these same viruses are responsible for some of the most complex and devastating human diseases we deal with.
Including a really significant portion of the global cancer burden.
Right. Which is wild. It's a David and Goliath situation, but in this version, David is a microscopic loop of DNA, and Goliath is the human immune system.
And the human cell cycle control system. It's a fascinating contradiction, because we often think that biological complexity requires this massive blueprint.
Like you need a complex weapon to destroy a complex cell.
But biology teaches us that efficiency can be just as deadly. And today we're looking at the papillomaviruses and the polyomaviruses.
And if you are a medical student or just someone who really wants to understand the mechanics of viral oncogenesis.
How a virus actually causes cancer.
Exactly. This is the deep dive for you because our mission today is pretty specific. We want to look at this through the lens of the medical learner.
Build a mental model.
Build a model that helps you crush those single best answer questions on your exams, but also helps you understand what you're actually seeing in the clinic.
And we're using Murray's Medical Microbiology, Chapter 41, as our primary structural spine today.
That's the roadmap.
Right. And we are going to layer in some high-level mechanism stuff from Jowett's Chapter 43 when we get to the cancer pathways.
Because, let's be honest, you really can't talk about HPV without talking about cancer mechanisms.
Which is crucial. Understanding the mechanism is the only way to really make this stick.
Right. You can memorize lists of numbers, or you can understand why the virus does what it does.
And once you know why the numbers just sort of fall into place.
So let's start with a little bit of family history. Depending on how old your textbooks are, or maybe how old your attending physician is.
Right.
You might remember these two groups, papilloma and polyoma, being lumped together in one big happy family.
The Papillomaviruses family.
Yeah.
The old family.
Yeah, break that name down for us, because it's actually a pretty clever acronym.
It was incredibly efficient. It stood for PA, PO, VA, PA for papilloma.
Okay.
PO for polyoma, and VA for vacuolating agent.
Vacuolating agent, what does that mean?
It refers to the cytopathic effect they have on cells.
The way they damage the cell.
Right, specifically simian virus 40, or SV40, which is a polyomavirus. It was observed to cause these massive vacuoles or holes in the cytoplasm of infected cells.
So the name literally described the members and what they looked like under the microscope.
Exactly. But they broke up.
The band split.
They did. They've been split into two distinct families now. Papillomaviridae and Polyomaviridae.
Why the divorce?
Well, despite looking very similar under an electron microscope, their genome organizations are just quite different.
The sizes and the layouts.
Right. The sizes of the genomes and the orientation of the genes differ enough to warrant separating them.
But for the purpose of a learner or anyone trying to group these in their head, they still share a very important structural identity.
Yes. And there are three pillars to this shared structural profile that Murray really wants you to know.
Okay, let's anchor that. What's the profile?
First, they are both small viruses with an icosahedral capsid.
A 20-sided shell, basically.
Right. Second, they have double-stranded circular DNA. And third, and this is the big one, they are naked.
They are non-enveloped.
Exactly. They are naked.
And the mnemonic we use as naked usually means hardy right.
It is. And we need to really unpack why that matters, because it dictates literally everything about how you catch these viruses.
Because in the viral world, an envelope is just a stolen piece of cell membrane from the host.
It's a lipid bilayer.
Like a soap bubble.
Like a soap bubble. It's delicate, it dries out, it falls apart if you hit it with soap or acid.
So if a virus has an envelope like influenza or HIV,
it generally needs to stay wet to survive.
It spreads through droplets or body fluids.
But if a virus is naked, it means its outer shell is just made of this tough protein capsid.
So it's like wearing a tank instead of a raincoat?
Ideally. Because they are naked, these viruses are incredibly resistant to drying out. Desiccation doesn't bother them.
They're resistant to detergents, too.
Right. They can survive out in the environment on surfaces, what we call fomites.
And this is why you can get warts from walking barefoot on a gym floor.
Or sharing a towel.
Yeah.
Exactly. They can even survive the acidic environment of the GI tract.
Though for today's discussion, we are mostly focused on direct contact and respiratory transmission.
True. But the key takeaway for you listening is naked viruses are tough. They persist.
And that persistence is a theme we are going to see again and again today.
Definitely.
Okay, let's dive into the first big player, the heavyweight champion of this chapter, Human Papillomavirus, or HPV.
This is a massive topic.
It is. Murray describes the structure as an icosahedral capsid about 50 to 55 nanometers.
And inside that capsid is a circular DNA genome of about 8,000 base pairs.
8,000.
Yeah, to put that in perspective, the human genome is 3 billion base pairs.
So HPV is working with a tiny, tiny instruction manual.
But it's very efficient. And we need to focus on two specific viral proteins right off the bat, L1 and L2.
L stands for late, right?
Correct.
Yeah.
The papillomavirus genes are divided into early, or E genes, and late, or L genes.
And the late genes do what?
The late genes encode the capsid, the shell itself. L1 is the major capsid protein.
So it's the one that makes up most of the structure.
Yes, and it's also the viral attachment protein. It's the grappling hook that grabs onto the host cell to start the infection.
And there is a huge clinical link here regarding L1. It's not just a structural detail. It's literally the basis of modern medicine's fight against this virus.
Massive link. If you know that L1 forms the capsid, you essentially know the composition of the HPV vaccine.
Because the vaccine is made of what we call virus-like particles, or VLPs.
Virus-like particles, it's the ultimate decoy.
How does that work?
Well, scientists discovered that if you express the L1 protein in a yeast cell or an insect cell, the L1 proteins will just spontaneously self-assemble.
Into empty capsids.
Right. They look exactly like the virus on the outside.
But they're empty. No DNA.
Completely empty.
Yeah.
No genetic material, just the shell.
So the immune system sees it and freaks out.
It creates potent neutralizing antibodies against them. But because there's no DNA, they literally cannot cause disease.
So knowing the structure of L1 explains the pharmacology of the prevention. I love that.
That's a great anchor for the exam.
Now let's talk about the life cycle. Murray uses this concept that I really want to expand on. The idea that the virus's life cycle is completely tied to the life cycle of the skin cell itself.
Yes, this is the skin elevator mental model. It's the absolute best way to visualize HPV replication.
Because to understand HPV, you really have to understand the skin.
Let's build the skyscraper.
All right, imagine the skin or the mucosa is a skyscraper. The bottom floor is the basal layer.
These are the stem cells. They are the only cells in your skin that are actively dividing.
Everything above them is just maturing and eventually dying.
Right. And the virus has to get to that ground floor.
It has to, because HPV is very particular. It cannot infect the dead skin on the surface.
It requires a break in the skin, a microabrasion.
Just a tiny scratch to access those basal cells?
This is why sexual transmission or rough contact facilitates infection. You need those microscopic tears to open the door to the lobby.
Okay, so the virus enters through a scratch, finds a basal cell, and enters the lobby. What happens next?
It establishes infection. But here's the catch. HPV is so small, it doesn't carry its own polymerase enzyme for replicating its DNA.
It left its tools at home.
It doesn't have the space. So it's entirely dependent on the host cell's machinery.
So it just sits in that basal cell?
Sit there replicating its DNA just a little bit, keeping pace with the cell dividing. It's what we call low copy number maintenance.
It's basically hitching a ride, not causing any real trouble yet.
Not yet. Now, as that basal cell divides, one daughter cell stays in the basement to keep the stem cell line going.
But the other one gets on the elevator.
It starts to ride up. It differentiates. It moves into the prickle cell layer or the stratum spinosum.
And as the elevator goes up, the environment inside that cell changes.
Drastically. The cell changes shape, it produces different keratins, and the whole transcription factor environment shifts.
And the virus detects this change.
It realizes, okay, we are moving up. The cell is differentiating.
And that signals the virus to do what?
To ramp up production. In the middle floors, the spinous layer of the virus starts replicating its DNA in much higher quantities.
This is vegetative replication.
Yes. But it's not building the shell yet. It's just making thousands of copies of the blueprint, the DNA.
Okay, so we're moving up to the penthouse now. The stratum granulosum and the stratum corneum.
The penthouse is where the cell is terminally differentiated. It's effectively dying.
Turning into a tough bag of keratin.
Exactly. And this is where the virus finally expresses those late genes we talked about, L1 and L2.
It builds the capsids.
Builds the capsids, stuffs the DNA inside, and creates thousands of infectious virions.
And then?
Then the skin cell dies and sloughs off. which is just normal skin physiology. We are constantly shedding dead skin.
But now that dead skin is loaded with infectious virus.
So the shedding of the virus is perfectly tied to the shedding of our skin.
And the skin elevator model explains why HPV is notoriously difficult to grow in a lab.
You can't just throw it in a petri dish with some liquid media and generic cells.
It won't work.
No, it requires the 3D architecture of differentiating skin to complete its life cycle. It needs that elevator ride to turn on the late genes.
That makes total sense. Now, before we leave the cellular level, we have to talk about the coilocyte.
Yes, the coilocyte.
This is a word that shows up on every pathology exam. If you are looking at a slide, how do you know HPV is there?
The coilocyte is the absolute hallmark cytopathic effect of HPV.
So if you look at a pap smear or a biopsy...
You see these squamous epithelial cells, the keratinocytes that look enlarged.
And the nucleus.
The nucleus is often shriveled. We call it pinotic.
Yeah.
And eccentric, pushed to the side.
But the defining feature is the halo.
Yes, a large, clear halo surrounding the nucleus.
A large, clear halo. That is your visual anchor.
Right. That paranuclear cytoplasmic vacuolization. Fancy words for a clear halo around the nucleus. That is the coilocyte.
If the question describes that or shows you an image of a cell that looks like it has a hole punched through it with a dark little raisin in the middle.
The answer is HPV.
A hole with a raisin in the middle. I like that. Okay, let's shift gears. We've built the virus. We've ridden the elevator.
Now the dark side.
Yes, oncogenesis. How does this virus actually cause cancer? This is the high-yield mechanics section.
This is where we move from the late genes L1 and L2 to the early genes, specifically the E genes.
And there are two villains in this story, E6 and E7.
The brake cutters.
That is the perfect analogy. To understand this, we have to picture the cell cycle as a car.
The process by which a cell decides to divide.
Right. In a healthy cell, you don't want the car speeding out of control. Uncontrolled speed is cancer.
So the cell has braking systems. These are the tumor suppressors.
And the two most famous tumor suppressors are P53 and RB.
Let's start with P53.
Yeah.
This is the guardian of the genome.
Think of P53 as the emergency brake.
Or maybe the security guard monitoring the highway. Its job is to constantly scan the DNA.
And if it sees damage...
Or if it sees the cell trying to divide when it shouldn't, it pulls the brake.
It stops the car.
It halts the cell cycle right at the G1 to S checkpoint to allow for repairs.
And if the damage is too bad to fix...
It triggers apoptosis. It basically drives the car off a cliff to save the rest of the highway. It kills the cell to prevent a tumor.
Brutal, but effective.
And RB, or the retinoblastoma protein, is like the regular foot brake or a red traffic light.
How does it work?
It binds to transcription factors called E2F.
E2F is the gas pedal.
Right. And as long as RB is holding on to E2F, the car sits at a red light. It cannot enter the S phase.
Which is where DNA replication happens.
Exactly.
So we have an emergency brake, P53, and a red light, RB. Enter HPV. Why does HPV care about these brakes?
The virus has a logistical problem. It needs the cell to replicate its DNA, so the virus can hijack the polymerase to replicate its own DNA.
Right, because it didn't bring its own.
But differentiated skin cells are usually sitting at a red light. They aren't dividing.
Which is maturing.
So the virus produces E6 and E7 to force the issue.
Let's break down the crime. Who strikes first?
Conceptually, think of E7 acting first. E7 binds to ARB.
Specifically, the P105RB form.
Yes. It binds to it and knocks it off the E2F factor.
It basically reaches overside, pushes the foot off the brake, and slams the gas pedal.
It runs the red light. It forces the cell into S phase. Now the machinery is active and the virus can replicate.
Okay, so the car is speeding, but wouldn't the security guard P53 notice that?
Normally, yes. The cell would sense this unnatural growth and P53 levels would spike to pull the emergency brake and kill the cell.
But the virus is ready for that.
That's where the viral protein E6 comes in. E6 binds to P53.
And it doesn't just block it.
No, it destroys it. E6 recruits a host enzyme called ubiquitin ligase.
Ubiquitin ligase.
It basically tags P53 for the cellular trash compactor, the proteasome.
It ties up the security guard and throws him out the window.
Exactly. So E7 cuts the regular plug and E6 cuts the emergency brake.
And just to add insult to injury, E6 also activates telomerase.
Which we know keeps the ends of chromosomes long, essentially giving the cell immortality.
So now you have a cell that is dividing uncontrollably, ignoring stop signals, and refusing to die.
That is the exact recipe for cancer.
Yeah, you mentioned something really interesting in the pre-show notes. The virus doesn't actually want to cause cancer.
No, it doesn't. Cancer is actually a dead end for the virus.
It's an accident.
It is. This is a very important nuance that Murray points out. In a wart, which is a benign infection, the viral DNA is floating around in the nucleus as a circle.
It's episomal.
Right. It's making E6 and E7, but in tightly controlled amounts. Just enough to keep the elevator moving and the DNA replicating.
But in cancer,
In cancer, the viral DNA often accidentally integrates into the host human DNA.
it splices itself right into our chromosomes.
And when it does that, the circle breaks. And where does it break? It almost always breaks right in the middle of the E2 gene.
And what does E2 normally do?
E2 normally acts as a repressor for E6 and E7. It keeps them in check.
It says, okay, guys, we need a little bit of gas, but don't floor it.
So if integration breaks E2,
You lose the repressor, E2 is gone.
suddenly E6 and E7 production goes through the roof.
Yeah.
You have absolutely no brakes, full gas, and the security guard is dead.
That's when you get malignant transformation.
It's essentially a genetic accident.
Yeah.
The virus gets trapped in the DNA and the host gets cancer.
That is a fascinating mechanism. It explains so much. And it also explains why high-risk types are different from low-risk types.
Right. High-risk types like HPV 16 and 18 produce E6 and E7 proteins that bind P53 and ARB with a much, much higher affinity.
They're just better at cutting the brakes than the low-risk types found in simple warts.
Exactly.
Speaking of types, let's get into the clinical syndromes. This is the numbers game for the boards.
There are over 100 types of HPV, but for the medical student, you really only need to memorize a specific handful.
Right, we categorize them by tissue tropism, skin versus mucosa, and by risk benign versus cancer.
Let's start with the skin. Cutaneous warts.
These are your common warts, verruca vulgaris, and plantar warts on the feet.
The key types here are 1 through 4. Specifically, types 1 and 2 are very common on the soles of the feet.
And these are completely benign.
Yes. They can be painful and they can last for years, but they're generally self-limited.
There's a classic vignette for this, the carpenter's finger.
Ah, yes. A carpenter has rough warts on his fingers. He tries to cut them off, burn them off, but they just keep coming back.
And then one day they just disappear.
Spontaneous regression.
Why does that happen?
That spontaneous regression is the immune system finally figuring out the game. It recognizes the viral antigens and mounts a response to clear the virus.
It highlights that cell-mediated immunity is key to controlling HPV.
Okay, moving to the mucosa. This is where we split into low risk and high risk. Let's do low risk first.
The numbers to know here are 6 and 11.
HPV 6 and 11. These cause condyloma acuminatum, anogenital warts.
These are benign, flesh-colored, cauliflower-like growths.
They don't kill you, but they can be socially and psychologically very distressing for patients.
But 6 and 11 have another presentation that is incredibly high yield for exams involving babies.
Yes, laryngeal papillomatosis.
How does that happen?
If a mother has active genital warts type 6 or 11 during childbirth, the infant can aspirate the virus during passage through the birth canal.
And the virus infects the respiratory tract.
Specifically the vocal cords. The baby developed benign tumors on the vocal cords.
What's the exam clue there? What are we looking for in a question stem?
Look for a young child, maybe toddler age, presenting with a weak cry, hoarseness, or even stridor.
Difficulty breathing.
Right. It's recurrent. You laser the tumors off and they grow back. It can actually be life-threatening if it blocks the airway, even though it's not cancer in the malignant sense.
Got it. So 6 and 11 equals warts and weak cry.
Warts and weak cry. Good anchor.
Now the killers. The mucosal high-risk types.
Type 16 and 18. These are the big ones.
They are responsible for the vast majority of cervical cancers.
HPV 16 alone accounts for about 50% of cervical cancers, and 18 covers another 20%.
So 70% right there. And cervical cancer is obviously the headline here, but it's not the only one.
No, we really need to broaden our scope. These viruses also cause anal cancer, penile cancer, vulvar and vaginal cancer.
And increasingly important, oropharyngeal cancer.
Squamous cell carcinoma of the head and neck.
Is that the throat cancer we hear about?
Yes, specifically the base of the tongue and the tonsils. The incidence of this is rising rapidly, particularly in men.
And it is driven largely by HPV 16.
Almost entirely.
And there's a crucial link with HIV and AIDS here as well from the Jowet's chapter.
Absolutely. Recall that we said the immune system usually clears these infections eventually. In patients with HIV, specifically uncontrolled AIDS.
They lack that T-cell surveillance.
Right. Their CD4 counts are depleted. So they are at significantly higher risk for developing these aggressive HPV-driven cancers.
Particularly anal and cervical carcinoma.
It's considered an AIDS-defining illness in some contexts. The virus just runs unchecked.
Okay, let's talk diagnosis, treatment, and prevention. Diagnosis usually starts with the Pap smear.
The Papillomaviruses smear. This is purely cytology.
We aren't necessarily looking for the virus itself.
No, we're looking for the effect of the virus on the host cells. We are hunting for those coilocytes we mentioned earlier.
The raisins with the halos.
Or for dysplasia. Abnormal growth patterns that we grade as CIN 1, 2, or 3.
Cervical intraepithelial neoplasia. But we can also test for the virus directly now, right?
Yes. HPV DNA testing, usually by PCR, is now standard, often as co-testing with the Pap.
It tells you not just is there a virus, but is it type 16? Is it type 18?
Which helps stratify risk. If a woman has a weird Pap smear, but is negative for high-risk HPV, you can relax a bit.
But if she's positive for HPV 16...
You're watching her like a hawk. You might go straight to colposcopy.
Treatment. If you have a wart, you burn it or freeze it.
Ablative therapy. Cryotherapy with liquid nitrogen electrocautery or salicylic acid.
We're just physically destroying the infected elevator shaft.
Right. For genital warts, we also use a cream called imiquimod.
Imiquimod. That's a toll-like receptor agonist.
It is. It binds specifically to TLR7. It's essentially calling in the cavalry.
It stimulates local inflammation,
tricking the immune system into attacking the area and clearing the virus. It's immunotherapy in a tube.
There's also an antiviral mentioned in the text, Cidofovir.
Yes.
Now, wait a minute. We said earlier HPV doesn't have its own polymerase.
Right.
Cidofovir is a DNA polymerase inhibitor. How does that even work if there's no viral polymerase?
It's a bit of a special case. Cidofovir is a nucleotide analog. It gets incorporated into DNA.
Human DNA.
Yes, but in HPV-infected cells, the host polymerase is running wildly out of control because of E7.
Right, because it pushed the gas pedal.
So Cidofovir seems to be preferentially incorporated in these rapidly cycling cells.
Yeah.
And it triggers apoptosis.
Oh, I see. It effectively selectively kills the infected cells because they are the ones synthesizing DNA so rapidly.
Exactly. It targets the consequence of the infection.
Mm-hmm.
It's mostly used in severe cases like those recurrent laryngeal papillomas or in immunocompromised patients.
Okay, the biggest win in this field, arguably in modern cancer prevention, the vaccine, Gardasil 9.
This is a huge public health triumph. It's a 9-valent vaccine. That means it covers 9 distinct types.
Let's list them just for completeness so listeners have it.
It covers the 2 wart types, 6 and 11, and it covers 7 cancer types, 16, 18, 31, 33, 45, 52, and 58.
That covers, what, about 90% of cervical cancers?
Correct, and the recommendation is to start early, age 11 or 12 for both boys and girls.
Why boys? I mean, obviously to prevent penile and anal cancer, but there's a bigger picture there.
Herd immunity. If boys don't carry it, they can't transmit it to girls.
Makes sense.
Plus, as we mentioned, oropharyngeal cancer is becoming a major issue for men. The vaccine protects against that, too.
It's literally an anti-cancer vaccine.
It's incredible.
All right, that's HPV. Let's pivot to the cousins, the polyomaviruses.
Poly refers to many and oma to tumors.
Historically, these caused many tumors in mice, which is how they got the name. But in humans, the story is a bit different.
Very different. Structurally, though, they are very similar to HPV.
Almost identical. Double-stranded DNA, circular naked capsid, slightly smaller genome, about 5,000 base pairs.
But the oncogenic machinery is slightly different. Instead of E6 and E7, they use something called a T antigen.
The large T antigen.
Think of this as the Swiss Army knife of viral proteins. In HPV, E6 handled P53 and E7 handled RB.
They split the work.
But in polyomavirus, large T antigen does both. It binds P53 and RB simultaneously.
It's incredibly efficient. One protein takes out both breaks.
Yes, and we have to mention SV40 here. It stands for simian virus 40.
It's not a human virus, but it has a crazy history.
It does. Back in the 1950s and 60s, the early polio vaccines were grown in monkey kidney cells.
And it turned out those monkey cells were naturally infected with SV40.
Millions of people were inadvertently injected with SV40, along with their polio vaccine.
That sounds absolutely terrifying. Did it cause a cancer epidemic?
Surprisingly, no. Despite SV40 being a very potent tumor virus in hamsters, extensive tracking of those millions of people has not shown a definitive link to human cancer clusters.
Bullet dodged. But it remains a huge area of study and a real cautionary tale about biologic manufacturing.
Absolutely. Okay, let's talk about the human polyomaviruses that actually do cause disease.
We have 2 main characters here, BK virus and JC virus.
We call these the sleeping agents, because for most of us listening, they're already inside us fast asleep.
The narrative arc here is crucial for exams. Act 1 is childhood.
You inhale the virus, that's a respiratory transmission, you get a mild cold, or maybe nothing at all. Act 1 ends.
Act 2 is latency.
The virus spreads through the blood and finds a home. For BK, it settles in the kidneys.
And for JC?
It settles in the kidneys, B cells, and monocytes. And it just goes dormant. It enters latency.
It's ubiquitous. About 70 to 80% of adults have antibodies to these.
It's exactly.
Act 3 is the trigger.
Immunosuppression. This is the key. These viruses rarely, if ever, cause disease in healthy people.
But if you have AIDS or a transplant,
The immune surveillance drops. The guards go away, and the virus wakes up.
let's take them one by one. BK virus, what's the mnemonic anchor?
BK stands for bad kidney. This is the virus of the renal transplant patient.
So you get a new kidney, you're on heavy immunosuppressants to stop rejection, and BK wakes up.
Exactly. And it attacks the graft. It causes polyomavirus-associated nephropathy.
You see rising creatinine.
And you might see ureteral stenosis, narrowing of the ureter.
And there's a specific presentation in bone marrow transplants too, right?
Yes, in bone marrow recipients, it tends to cause hemorrhagic cystitis. The patient has painful bloody urine.
Okay, so BK equals bad kidney and bloody urine.
Got it. Now JC virus.
JC stands for junky cerebrum. This virus targets the brain.
And the disease is PML, progressive, multifocal leukoencephalopathy.
That is a mouthful. Let's break it down word by word.
Progressive means it gets worse rapidly. Multifocal means it hits many spots in the brain simultaneously.
And leukoencephalopathy.
Leuko means white. It attacks the white matter of the brain.
The white matter is myelin,
Correct. The JC virus specifically infects and kills oligodendrocytes.
and those are the cells that create the myelin sheath around your neurons in the CNS.
Yes. Without myelin, the signals just stop. The neurons can't communicate.
Who gets this?
Historically, this was a major killer in AIDS patients, specifically when CD4 counts drop below 200.
With modern antiretrovirals, we see it less, but it's still a threat.
We also see it now in patients with multiple sclerosis taking a drug called natalizumab.
Right, because that drug blocks immune cells from entering the brain, which stops the MS.
But also stops the immune system from keeping JC virus in check. It's a tragic trade-off.
What does the patient look like when they present?
It's not subtle. We call it clumsy. They develop hemiparesis weakness on one side. Vision changes, difficulty speaking, coordination issues.
It looks like a stroke, but it's progressive over days to weeks. It's exactly.
And on an MRI.
You see non-enhancing lesions in the white matter. Non-enhancing is the key word.
Why is that important?
It means there isn't a massive inflammatory ring because the immune system isn't really fighting it. The patient is immunosuppressed.
And if we somehow biopsy the brain,
You see enlarged oligodendrocytes with intranuclear inclusions. The virus is just packed inside the nucleus of the cell.
grim, very grim.
Yeah.
Okay, one last polyomavirus to cover. The newcomer, Merkel cell polyomavirus.
MCV. This was discovered fairly recently in 2008.
This one is distinct because unlike BK and JC, this one is a direct cause of cancer in humans.
Yes, Merkel cell carcinoma. It's a rare, aggressive skin cancer of neuroendocrine
It
origin.
looks like a red or purple nodule, usually on sun-exposed skin.
And in these tumors, the virus is clonally integrated into the host DNA, just like HPV and cervical cancer.
So HPV and Merkel cell are the true oncogenic viruses in this group. BK and JC are opportunistic destroyers, but not usually cancer causers.
Precisely. That's a great way to separate them. All right, that is a ton of information. Let's solidify it. We are going to do a rapid recall session. I'll ask the question, pause for a second so you, the listener, can think of the answer, and then our expert will break it down.
Let's do it.
Question 1. A renal transplant patient develops rising creatinine and ureteral stenosis. Biopsy shows intranuclear inclusions. Which virus?
Answer is BK virus. Anchor is bad kidney in transplants. The immunosuppression allows the latent virus in the kidney to reactivate and damage the new graft.
Question 2. On a pap smear, cells appear with a large clear halo around a shrunken nucleus. What is this cell called, and what viral protein is driving cell cycle progression by inhibiting RB?
Answer is coilocyte and the E7 protein. Anchor is E7 beats RB. The halo is the visual hallmark, and E7 is the protein that hits the gas pedal by removing RB from E2F.
Question 3. An AIDS patient presents with hemiparesis and vision loss. MRI shows non-enhancing white matter lesions. Which cell type is being destroyed?
Answer is oligodendrocytes. The diagnosis is PML caused by JC virus. The virus specifically targets the myelin-producing cells leading to demyelination and those white matter symptoms.
Question 4. Which HPV types are contained in the 9-valent vaccine to prevent genital warts specifically?
Answer is types 6 and 11. 16 and 18 are for cancer, but 6 and 11 are for warts. Remember, the vaccine is a mix of VLPs covering both the nuisance types and the killer types.
Question 5. What is the mechanism of action of cidofovir in treating severe papillomavirus infections?
Answer is inhibition of host cell DNA polymerase. Recall that these viruses don't have their own polymerase, so the drug must target the host's machinery, selectively affecting infected cells that are rapidly dividing.
Question 6. Mechanistically, how does the SV40 large T antigen differ from HPV oncoproteins?
Answer is large T binds both P53 and RB simultaneously, whereas HPV requires two separate proteins, E6 and E7. It's a matter of efficiency.
Excellent. For consolidation, I advise you all to review Murray Chapter 41, specifically the clinical syndromes table for HPV types and the pathogenesis box for polyomaviruses.
Definitely check that table. It's money for the boards.
So let's wrap this up. What is the big takeaway?
Small DNA viruses equal big impact via cell cycle hijacking. HPV has epithelial tropism. It uses E6 to kill P53 and E7 to block RB. This leads to warts or, in high-risk cases, with integration cancer.
And the polyomaviruses?
They establish latency in the kidneys and reactivate in immunosuppression, attacking the kidney for BK or the brain for JC.
And a final provocative thought for you to chew on. We vaccinate against HPV to prevent cancer. We know it works.
It works incredibly well.
If we could develop a vaccine against EBV or other ubiquitous viruses, how many other spontaneous human cancers might just disappear?
It's a fascinating frontier. It really makes you wonder how many cancers are just viral accidents.
Thanks for diving deep with us. Read the chapter, and we'll see you next time.
Stay curious.